Hey guys, we're going to take a few minutes and go through something that's very commonly seen, whether it's on the aircraft, on the ambulance, or in the ER, is DKA. And we're going to speak more to the pathophysiology of it and focus more on that as opposed to the treatment of it. And of course, we will discuss treatment, but to a greater extent, we'll discuss the pathophysiology. So let's just jump right into this. Before we get rolling here, it's important for me to mention that the source of all the recommended treatment guidelines comes from your 2019 MCES protocols. I also got some information from Up to Date on the article entitled Diabetic Ketoacidosis and Hyperosmolar Hypoglycemic State in Adults, treatment dated July of 2019, and there's various other topics that I researched out on Up to Date. So we're going to go ahead and get started with some terminology that is common. A lot of this stuff you already know. Some of it may be a little bit of a refresher from your chemistry days, and some of it you may have never heard of. So diabetes mellitus type 1 is caused by the body's immunity attacking the beta or insulin secreting cells of the pancreas. Type 2 is caused by those beta cells being dysfunctional or the cell is resistant to insulin. So if you remember back from school, a cation is anything with a plus sign behind it. So if you draw chemistry and you see a positive side behind it, it is a cation. And it is basically nothing more than a positively charged ion. In contrast, an anion has got a negative charge to it. So same thing goes, anything that's got a negative sign behind it is a negatively charged ion. So the anion gap is the difference between the measured anions and cations, and the normal ratio is 1:1 to maintain electroneutrality, meaning there should be, for each negatively charged one, there should be a positively charged one somewhere in the body to equal each other out. So at this point, you're probably asking yourself, if there's a positively charged ion for each negatively charged ion in the body, then why do we even have an anion gap, and why is there a normal value range for a gap? So the explanation for this is pretty simple. The anion gap is a artificial calculation, and the reason why it's an artificial calculation is due to the fact that a common chemistry that pretty much everybody draws on their patients who come through as part of a basic lab profile does not measure all the ions in the body. So you've got a bunch of ions that could possibly make it into this calculation, but they're not readily available for our labs to measure. So therefore, we don't calculate those in, and we have an anion gap for that reason. So as you can see, looking at this chart, my point about what we normally measure on a chemistry and what we have access to in a lab. So these are all the positive and negative ions, and you can see that there's a huge amount that we don't or we're not able to obtain in the transport environment, and a lot of times even in the ER ICU environment. As I was drawing this picture in the office, I constantly had my partner in my right ear telling me that it would probably be a better idea to copy and paste one off the internet, and looking at this picture now, I kind of agree with him. You can always depend on your partner, to be totally honest with you. However, the pancreas is the major organ that regulates our glucose, and more specifically the alpha cells and the beta cells that live on the pancreatic islets. So let's discuss a couple of hormones. First, we'll talk about glucagon, and glucagon is released from the alpha cell, and the alpha cell is part of the pancreatic cells on the islet of Langerhans, or more commonly today called the pancreatic islets. But the glucagon signals the liver to build and release glucose. So in a low glucose state, these glucagon is released from the alpha cells. They go to the liver. They tell the liver, hey, I need some glucose. But they also stimulate the uptake of free fatty acids by the liver for oxidation to ketone bodies. And we'll get more into that as we progress. Insulin is a hormone that is released by the beta cells. Now, the beta cells lie close in contact with the alpha cells in the pancreatic islets. And we know that insulin is the main player for getting glucose inside the cell for cellular metabolism of glucose. But it also has another very important function, and that is the inhibition of lipase from breaking down triglycerides into free fatty acids. So what happens when you go to the cafeteria and you eat that taco salad because it's Tuesday, or maybe you go and you load up on a bunch of sugary sweets and you have a big glucose load? Or maybe you have just finished a strenuous workout, maybe you ran a marathon, you've been working outside all day, you're doing 4 flights in a night. Either way, something has trashed the glucose stores that you've got circulating in your body. Because I'm a very visual learner, I have to kind of think about these cells that are arranged in this cluster as more of a hormonal thermostat. So if you look at this cutaway, the cells are very close together. The alpha cells and the beta cells, they lay very close contact with each other. And there's all these little capillaries that run through, and they're always sampling the glucose level of the blood. So as blood flows through these cells, the cells are constantly trying to determine what hormone needs to be released. So in someone who has a glucose level that is low, the alpha cells go into action. They release glucagon, which obviously is going to go tell the liver, hey, we need glucose. In contrast, if the sugar is very high, the beta cells are going to release insulin, which will help move some of the glucose inside the cell. So if you think about the cells as a thermostat like I do, maybe that helps you, maybe it doesn't, but that's how it kind of works. And it's always sampling the glucose level to determine what hormone is best suited at the time. If you're anything like me, you kind of learn this stuff back in school to pass an exam, and then you kind of put it out of your mind. But either way, you retain a little bit of it. So we're going to kind of go back through it just briefly, and I'm going to try to simplify it as much as I can and look at the normal pathophysiology of normal metabolism. So in a normal healthy person that doesn't have any issues with insulin, once insulin arrives at the cell, it hits receptor, and once the receptor is stimulated, a channel opens and allows the passage of glucose inside the cell. Once inside the cell, the glucose molecule goes through a process of glycolysis, and glycolysis is an enzymatic reaction that causes the breakdown of the glucose molecule into 2 pyruvate molecules. Now, these pyruvate molecules, along with oxygen, are allowed to enter into a Krebs cycle where they produce ATP. So without insulin and without glycolysis, how do we then produce energy? So in the event of DKA, you have little or no insulin production. And without insulin binding to the receptor, you have no way for glucose to get into the cell. And with no glucose in the cell, you have no glycolysis. Insulin is a hormone that is released by the beta cells. Now, the beta cells lie close in contact with the alpha cells in the pancreatic islets. And we know that insulin is the main player for getting glucose inside the cell for cellular metabolism of glucose. But it also has another very important function, and that is the inhibition of lipase from breaking down triglycerides into free fatty acids. So in the liver cells, mitochondrial matrix, the free fatty acids are broken down and converted into acetyl-CoA. And if you remember from studying the Krebs cycle years and years ago, acetyl-CoA is a major ingredient in the production of ATP. So once this acetyl-CoA is released back into the bloodstream and it goes to the different organs and cells and tissues, it's able to be taken up and used in the production of ATP. Now, obviously, this is not the way we were designed, and it is not the best, most efficient process, and it's a lot of steps, but it will protect the body in a time of stress whenever we don't have enough glucose in order to produce ATP. So we know that this is a DKA lecture, and we know that at some point we've got to talk about ketones, but if we have an energy source from free fatty acids, why do we produce ketones and where do they come from? So now you have a situation where you have an excessive number of free fatty acids being produced because of the lack of insulin. And as these free fatty acids are pouring into the bloodstream and going to the cells, the Krebs cycle can no longer keep up with the overproduction of the free fatty acids, and they start converting the free fatty acids into ketone bodies through the ketogenesis pathway. So one of the reasons why we do produce ketones is the fact that the brain uses the ketones for energy production and for the production of ATP. And the brain is unable to use free fatty acids for the energy source. So they are used by the brain cells to produce ATP, and that's one of the reasons why we have to have ketones, or else the brain cells would end up dying off. Through the ketogenesis pathway, we produce 3 ketones, those being acetone, acetoacetate, and hydroxybutyrate acid that we call beta for short. The acetone is very unstable and it disassociates and becomes a gas, and that is what we smell on the breath of some of our DKA patients. So your ketones are busy producing energy, but you're steady producing these ketones and when you're in this state. So what happens when you have too many ketones? So what you have at this point is you have all these extra ketones that really have no place in life. They have no purpose. So what they're going to start doing, they're going to start breaking down. So the way they break down is the hydrogen starts splitting off of this group here, and you're starting to put a whole lot of extra hydrogen into your bloodstream. So acidosis develops because you all of a sudden have all these ketones that are acidotic, and then you start splitting off this hydrogen from this OH group, and it is also acidotic. So you start developing acidosis, or your patient starts developing acidosis pretty rapidly. So let's take a second and just kind of discuss how an anion gap actually develops. So how do we develop an anion gap? An anion gap, if you recall, is the difference between the positives and the negatives, and it should be 1 for 1, but we develop a gap because we start having more negatives than positives. So if you remember, by looking at this group right here, we have there used to be a hydrogen attached to this base, but as you hyperaccumulate ketones, this starts to break apart and you start breaking off these hydrogens off of these bases. And what you have is you have an excess of hydrogen in the cell, and the hydrogen starts combining and turning into carbonic acid and starts getting breaks down further into CO2 and water, and we lose it. But what happens is we keep these bases, and when you have an excess of these negatively charged bases, you start to get a lopsided measurement where you start losing the hydrogen from the conversion to CO2 and water, but the bases are left behind. And at that point, you have way more bases which are negative than you do the hydrogens which were positive. So how do you calculate a gap, and what's a normal gap? So in order to calculate an anion gap, you'll draw a basic chemistry, and on that chemistry you're going to add together your chloride and your bicarb. Now on a chemistry, your bicarb is the same number as your CO2, so I guess I should have put here that you want to add together your chloride and your CO2. You take that number and then you subtract it from whatever your sodium number is. And that's going to give you a value. And a normal is 8 to 12 because, again, we talked about earlier how we don't measure all our anions or our ions in general, and we always have a gap. But the normal level is 8 to 12 as we talked about. However, anything above 12, you're starting to get into an anion gap acidosis. This is something that you got to know if you're doing critical care medicine or if you're taking care of patients in the ER, you're managing patients, because this is a very simple calculation that can give you a lot of information. So how do we start to close the anion gap? So in order to start closing the anion gap and return it to normal, you have to stop the process that first started the gap widening in the first place. So let's take a second and review this one more time just to make it good and solid. The function of lipase is to convert triglycerides into fatty acids. Fatty acids, once they overaccumulate, they start to cause the formulation of ketones. Insulin inhibits the action of lipase. So once you start giving the patient back insulin, the lipase is once again inhibited as it's supposed to be, and then the formation of free fatty acids stops and the subsequent formation of ketones stops. And once you stop the formation of the free fatty acids, you start to return your gap back to normal because you have restored proper metabolism. So let's take just a second and talk about what happens to the potassium in the DKA state. So as your glucose begins to rise and spills into the urine, we know that glucose is a water-loving molecule, and it starts to pull fluid in from all different directions. It pulls it from the intercellular space, it pulls it from the interstitial space. Either way, it pulls fluid into the vascular space. Once in the vascular space, we know it has to be eliminated from the body, and that's done through the renal system. But once you start to lose or spill glucose into the urinary system, you start to spill potassium because they kind of follow each other. So initially, when you lose glucose in the urine, you're going to lose potassium with it, and it's going to cause an initial drop. So if you come along at this point in the game and you pull their serum potassium, it's going to appear low because at that point it truly is low because it's being lost with the glucose. This is also what accounts for the severe dehydration. We're pulling a lot of fluid out, and we're dumping it through the kidneys and peeing it out. But then as it progresses, and you remember how we talked about when you have an excess of ketone formation inside the cell, and the ketones start to break apart, and you start to have an excess of hydrogen within the cell, hydrogen will actually exchange and force out the potassium into the bloodstream. So what you have at this point, if you come along and you draw their labs, it may appear that the patient's potassium level is normal or even high. Although it's high or normal in the serum, it's low in the cell because it has been forced out of the cell. Now, as you come along and you start insulin therapy and you start, insulin is reintroduced back into the system, and we know that once the insulin hits the receptor, it allows glucose passage back into the cell. We know it also takes potassium with it. So what you have then, if you come along at that point and you draw the potassium that used to be in the bloodstream is now being forced back into its cell. It's basically going back home. So it's going to cause a serum potassium level to drop. Now the heart doesn't really care why the potassium is low. It just knows it's low, and it shows it by decreasing contractility. You start getting your EKG changes and whatnot. But it's very important to know and to remain cognizant that as you start to correct your insulin deficiency, your potassium level is going to more than likely drop, and you need to be prepared to provide potassium replacement to the patient. And we'll have those guidelines in just a few minutes. We'll discuss them. So at what point do we begin to add potassium to our IV fluids? So current guidelines recommend that if a patient has a potassium of less than 3.3, then you should add 20 to 40 milliequivalents to each liter of fluid per hour. If the range is between 3.3 and 5.3, the recommendation is to add 20 to 30 milliequivalents to each liter of fluid, and we give that until the potassium reaches a 4 to 5 milliequivalent range. If the potassium is greater than 5.3, you want to hold the potassium until the patient's potassium level in the serum drops below 5.3. A point to consider prior to or along with giving IV potassium is the fact that potassium has got a high osmo rate. What this means is if your patient has still got a fluid volume deficit or they're in the midst of being rehydrated, you want to make sure that their urinary output is adequate, at least 50 cc's an hour, to prevent further dehydrating your patient. So we'll take just a second to kind of discuss insulin therapy and some other considerations when treating or evaluating someone for DKA. The initial therapy of DKA treatment involves giving the patient back the fluid that they've lost through urination and starting to correct the dehydration. So currently our protocols have got that we give the patient normal saline as a 2-liter bolus. We pretty much run those fluids wide open and get those fluids in as quickly as possible. And then we'll kind of cut it back to 10 to 15 milliliters per key per hour and reevaluate their hydration status. At this point, you want to make sure that you've got a Foley in so we can monitor the urine output. That becomes very important when we start giving the potassium back and we start gauging the effectiveness of our treatment. Insulin, we give insulin fairly frequently, and it is part of the treatment regimen for DKA, and if you've been listening or paying attention, you understand why now. But if you're coming in as a medic into the critical care world like I did, I never gave insulin before I got into the critical care arena. And the reason for that is we just simply don't have it. It's not in our protocols. It's, at least in my part of the state, you don't have insulin. I never touched it. But insulin, just for the medics that have not fooled with it, or probably maybe for some newer nurses, you give regular insulin. Humulin R is the only IV insulin that we give. Before we give insulin, something that is imperative that we do is we check their potassium. So current standards say that if you have a potassium level, serum potassium of less than 3.3 milliequivalents per liter, that you either hold your insulin until you can get your potassium in a little bit normal range, or you use extreme caution. And the reason why is your insulin is going to cause the exchange of potassium from your bloodstream into your cells. And once you start shifting potassium from your bloodstream into your cells, your serum potassium is going to drop. And we all know that you drop your potassium, your heart gets very irritated, and you can start to have arrhythmias and possibly even go into a systole. There's different dosing regimens for insulin, depending on what you read, depending on where you work, but some people give a loading dose of sub-Q insulin, some give a loading dose of IV insulin. I've seen it all different ways. But currently, as far as we're concerned, the standard that we use is 0.1 units per key per hour. For simplistic reasons, we'll mix 100 units in 100 cc's of fluid, and if you have somebody that is 70 kilos, your dose is 7 cc's an hour. If you ever get up into the 10 or 15 cc an hour range, you might want to look back at your calculation to make sure you calculate it right. This is not something you want to give somebody too much of. So you can expect a decrease in your glucose of 50 to 70 milligrams per deciliter per hour. So when you first start giving insulin, it is very important that you check that glucose at least once every 15 minutes within the first couple of hours. The problem is if you drop the glucose too rapidly, you can cause osmotic shift of fluid, which will cause the patient to have cerebral edema and subsequent brain damage and altered mental status, so on and so forth. So you want to, at the dose that we give it, it should drop your glucose in a controlled manner at a controlled rate that is not that doesn't induce that osmotic shift of fluid. When the glucose reaches about 300 milligrams per deciliter, we'll switch to D5NS at 125 to 250 cc's an hour, and that's because we're starting to get into that. We don't want to, at that point, we don't want to drop it too fast, and all of a sudden you've dropped their glucose to the point where they have developed that cerebral edema. So you want to look at changing that fluid over when you get down to 300 milligrams per deciliter. So what do we know about sodium in DKA? What we know is that as the glucose reaches 100, for each 100 above 100 that the glucose rises, the sodium will fall by 2. So with that being the case, if we have someone whose sugar is 500, we add 2 for each 100 milligrams per deciliter over 100 back to the sodium level. You can see the example below. So something that you might want to consider or look at is their sodium levels. So what happens and how is it affected? Well, if you think about it, your glucose, as we've said before over and over, it pulls a lot of fluid in from all different directions. So if you pull a lot of fluid in, you're going to get a dilutional hyponatremia. It's not a true hyponatremia, but it's diluted because you've added a whole lot more fluid that's not normally in the vascular space. And you come along and you draw your lab and it appears like it's low. So they've come up with a corrected sodium calculation. It's something you just kind of need to be aware of. So if you come along and you pull a sodium and you all of a sudden it's 127 and you're like, wow, it's 127. It's not really 127. It's diluted to a 127. So you'll have to kind of be familiar with the formula in order to calculate that out and get the correct sodium. So why is a corrected sodium important to those in transport medicine? And the answer to that is the fact that a lot of times we don't pick up patients in the acute minutes of their DKA crisis from an emergency room or a scene. Many times we're going out to ICUs where they've had therapy or fluid therapy underway for hours to days. And calculating the corrected sodium is important because it gives you a more truer picture of what their sodium actually is, and it prevents the patient from being hypernatremic, further dehydrating the cells. So current recommendations are to keep giving the patients normal saline, 0.9% sodium chloride, until the corrected sodium is above 135. Once the sodium reaches normal levels, we can consider swapping them over to a half normal saline to give them more electrolyte-free water, preventing the potential hypernatremia. Of course, you want to make sure that the patient is adequately rehydrated and they've got a good urinary output, and that you discuss this plan of care with your med control physician or the accepted physician. So I want to mention a word about sodium bicarb and when to give it and when not to give it. So Up to Date only recommends that you consider giving sodium bicarbonate with a pH of less than 6.9 with decreased cardiac contractility. So if you have a patient that is profoundly acidotic, less than 6.9, and their blood pressure is extremely low, or you have evidence of decreased cardiac output, then you want to call and speak with the accepting physician or med control physician in order to give or consider sodium bicarb. Otherwise, it's controversial and it tends to worsen their outcome. So a class of medications that we're starting to see come onto the scene as of late are the sodium glucose transport protein inhibitors. And what they do is they prevent the kidneys from reabsorbing glucose. So they pretty much keep the glucose levels within a normal range. Something to be aware of is that these medications have the potential to cause the patient to have euglycemic DKA, meaning their glucose can be in what we consider a normal range or slightly above normal, and the patient could be in rip-roaring DKA. So I've got a few of them listed here, and if you think that you've never heard of them until you start looking at the names and realize how much TV marketing actually affects you. So I've seen most of these medications advertised on television, but you need to become familiar with these medications, especially whenever you're trying to determine what may be wrong with somebody with a normal glucose. If they're on any of these medications, at that point it needs to be investigated or considered, even though their sugar may be in a normal level, that they may actually be in DKA. So what's the mechanism of how you can actually develop a euglycemic DKA? So the best way to kind of look at that is to go through a little brief case study, and let's kind of talk through this. So you have a 25-year-old male that comes into the hospital with signs and symptoms of dehydration, general malaise, just generally not feeling well. They start looking at his med list and the patient's on Invokana, and you know that Invokana is going to maintain a glucose level at a normal level by just the mechanism of the drug. But the patient also has an insulin pump. Now, I know an insulin pump is supposed to alert the user or the patient when there's a malfunction, but sometimes our patients are not educated enough on the device or they've never had a malfunction, so it's kind of a low index of suspicion for them, or maybe they don't investigate it. We know how our patients are sometimes. So the patient continues their Invokana unaware or unconcerned with the malfunction, or they don't investigate it, whatever the case may be. So the Invokana maintains their glucose levels at a normal level. So you come along and you check their glucose, and lo and behold, it's 140, 150. So that's not something that would raise our suspicions automatically for DKA. But at the same time, the patient's not had any type of insulin therapy, whether it's their own endogenous insulin or the pump, because the pump has quit. So the whole cascade of the previous 60 slides begins. All the pathophysiology that we've discussed is underway simply because their insulin is not getting to the receptors. It's not allowing glucose into the cell, and the whole cascade begins. So if you look at it from that standpoint and you maintain an open mind, and you know that these medications will cause euglycemic DKA, this is something that you should maintain a very high level of suspicion on when it comes to patients who take this class of medication. The entire purpose of this lecture and the way I kind of designed it was not to sit back and read a bunch of treatment protocols to you. Obviously, we know how to treat DKA, and we all know how to read. The whole goal of this was to do a very deep dive into the pathophysiology to kind of help you understand why we treat the way we do. And I hope that's kind of been accomplished. I hope you got something out of it. Any questions or comments, you're welcome to ask me. If I can't get the answer, I can find the answer for you. And I appreciate your time and attention.